So I am Mary LaFleur. I'm a social worker, and I work at Acadiana Cares. And I'm just going to talk to you for a few minutes about our program of recovery here. Again, I have no financial disclosures to make. Where we are, Acadiana Cares, we are an old nursing home that was donated to us about 15 years ago. So we were right off of Martin Luther King Drive, kind of the corner by I-49 and I-10. So we started a program called Seasons of Serenity a couple of years before I got here, maybe 3 years before I got here, so I'll say 13 years ago. Originally, we were just going to do an HIV substance abuse program. It was going to be 90 days. At the same time, St. Francis Foundation was going out, was having some issues, and they asked us to take over St. Francis as well. So it was kind of a happy circumstance that we're able to put those two programs together from the beginning. And now it's kind of morphed into one real program. What it looks like now is, and we do have two different levels of care in the residential program. Most of my clients will come from detox centers and acute care hospitals from across the state. I do take especially folks who are HIV positive, but not only people who are HIV positive. And I'll get more to that down the road. What else? So it's two different levels of care. It's 3.3 and 3.1 level of care with Medicaid. 3.3 is just like the first step down from 3.5, which would be 28-day program. And even though the insurance companies don't pay me very much or very often to do 3.3, we do it for everyone anyway. We do at least 20 hours of clinical services per week with that level of care. With the 3.3, we call that winter. It's when they first come in. We ask them to do the first 3 steps or so of recovery and a life story, and just try to make sure they have a real solid foundation. They gain a sponsor, and then they will go in about 6 weeks or so into what we call spring, where it's more work readiness, and they continue working with their sponsor. And at that point, they're doing about 5 or 6 clinical hours a week. If all that goes well, these days Medicaid is usually approving about 3 months of treatment. And I don't necessarily only go with what Medicaid says. I have had times where I've kept people longer, even though Medicaid was no longer paying. But in general, around 3 to 4 months after getting here, they will graduate. Many of them will choose to go into our recovery living program, which we have apartments on site, and so they can share apartments and do an intensive outpatient. So they'll pay a little bit of rent, and all their basic needs will be covered. They will work, and they will do IOP for 3 days a week and get an individual session per week. And they can stay in that program 3 to 6 months. We've tweaked it a little bit with COVID, but we're kind of tweaking it back at this point. And so that's the basics of the program. We just kind of looked at what happened last year, and even though it was a COVID year, we just wanted to look at some of our statistics. And if you see here, graduation rates, it's not terrific, but it's pretty close to average, maybe just a tad above average as far as people who complete program. 20 full graduation, 6 and 8% left with kind of maximum benefit, and 18% we asked to leave, 54% left their own accord early. Our summer program, which makes sense, that's IOP. So of the folks who came into treatment and stayed in treatment and then went to IOP, about half of those folks last year completed intensive outpatient, which hopefully means that they continued to do aftercare after that as well. They continued working and participating in 12-step programs. We've had folks now for 4 or 5 years of recovery who continue to come back to aftercare and are kind of an inspiration to our current clients. Just checking to see how I'm doing on time. I'm sorry. Plenty of time. Okay. So some of the things that we do, some of the, I think one of the buzzwords is evidence-based practice, and it's not just a buzzword, but we do try to do things that seem that work. And for each person, sometimes things are a little bit different. We do 12-step facilitation. We facilitate the first 3 steps and encourage people to continue to do step work outside of that. We do a relapse prevention, kind of a Gorski model relapse prevention work, where we try to get folks to figure out what kinds of things led to their previous relapse so that they can not do that again. Our counselors use motivational interviewing. Our horticulture therapy, it's not real deep involved like counseling, but I think the work itself is very soothing, and a lot of our folks really get into it. And you can kind of see a picture of the garden there. We do specific gender groups. If I have a certain amount of gay male participants, then we will separate out our males as well, not to isolate them or anything else, but that we do have someone that can really do some good work with them as well. So we do cognitive behavioral therapy, and then we have yoga twice a week. We teach folks culinary skills, money management, job readiness, all that kind of stuff. MAT I skipped over. So medication-assisted treatment. I do not have round-the-clock nursing with our level of care. And so we have decided not to allow folks to use medications such as Suboxone on the premises in our residential program, because I do not have nursing to kind of have custody of the medication 24 hours a day and on weekends. And that's not the only reason, but it's definitely a reason. We do offer naltrexone and Vivitrol. We figured out a couple of years ago how to get Medicaid to allow us to use Vivitrol. If you're not familiar, naltrexone is a daily pill that you can take, and it basically works for folks who have problems with opiates and with alcohol. And it helps with cravings, and it helps basically as an agonist, if I'm not mistaken, so that people cannot even get high if you're taking the medication. All right, right. And so we start them off with the oral naltrexone, and after a month or 6 weeks of being on the oral naltrexone, we can do the little magic thing that you have to do with Medicaid, and they will approve us to do the Vivitrol shot. The Vivitrol shot lasts for 30 days. And I really like for the folks who qualify to have that medication on board by the time they get into the apartment programs. It's definitely an additional tool. What I kind of try to call is it's an additional tool in the relapse prevention kit. So that when they're out there looking for work or out there working, if they're working in the bar and restaurant industry, it's much easier to me if they're on the Vivitrol shot to kind of resist temptation and not try to get high, because they're not going to get high. And it does help with cravings. I have had some people who have complained about the shot, so it's not panacea. It doesn't work for necessarily everyone, but it is good. So now we're just looking at some program effectiveness. We treated a total of 128 people last year. And the RW is Ryan White, which basically is folks who are HIV positive. We had 27% of our population was positive. And all those people who are positive, just to tell you about that a little bit, these days, the medications have drastically improved. With most people, we get them on medicine, and within 30 days, they are undetectable. And the new thing is that the CDC has recommended and promoted is that undetectable equals untransmissible. So basically, if they're on their medications and doing what they need to do, even if somehow they were able to share body fluid with someone else, that other person would not become positive because they would be untransmissible because they're taking their meds. And pretty much all of our clients become undetectable. It's a program requirement that you take your medicine when you come here. Let's see. This, I won't go into a lot of details. Basically, what we sort of noticed, which kind of makes sense, is that the longer someone stayed, the better chance they had of completing the program, graduating, and long-term success. Obviously, if someone leaves in a week or two, the chances of them graduating is zero, and the chances of them remaining sober post leaving is pretty low, unfortunately. So, we just found that folks who stayed at least 3.5 months or so were more likely to graduate, and then a lot of those folks were more likely to go into the IOP and stay sober down the road. And so of those people, we really just started monitoring the naltrexone and Vivitrol thing this year. I do have a nurse practitioner. I have a clinic on site, so I'm very fortunate. And my mental health nurse practitioner has been offering it to people, and we've just gotten better at reinforcing that in our treatment team, and in just trying to encourage folks to go ahead and get on the medication. And we have had folks who have resisted, folks who have refused. It is their right to refuse. But we have seen people who were taking the medicine did have a better outcome in the end. So we had this green figure, 9 people graduated taking the naltrexone out of the 21 who qualified. All right. Check my time. Plenty of time. I think we gave you these questions. The naltrexone Vivitrol is the same medicine. And I guess what I'm saying is there is no one approach to success for folks. And I'll speak about that just maybe a little bit more. When folks like Heath Ledger overdose and die, the press invites people on to speak, and they're like, oh, it doesn't make any sense. They could be alive today. And it's true that it may be true that if they were taking Suboxone or doing something similar, that person may still be alive. But it's not necessarily true. I do believe that medication-assisted treatment can be helpful, it can be appropriate. Most of the folks that we see here have been using for years and have failed either Suboxone or other things in the past. And we're still using other chemicals to get high, even on things like Suboxone. So again, I think there is no one answer for folks in treatment. And that here at Acadiana Cares, we do try to do a person-centered plan, and we try to help that one person figure out what are their best ways of recovery, what are their strengths, what are the things that they can do. And again, if they qualify for things like naltrexone and Vivitrol, we will absolutely encourage that. And I do believe that on an outpatient setting or in a different setting, that there are lots of folks who can benefit from things like Suboxone with appropriate care. And that they can do, I can't speak to that in this program. So Um, that's about all I have. Thank you.
All right, thank you so much, Mr. LaFleur. Attendees, if anyone has any questions for Mr. LaFleur, after Ms. Leffel's presentation, we will be doing a Q&A with both presenters. So Ms. Leffel, if you're ready and you want to share your screen, you can go ahead and start your presentation as well.
Hi, my name is Danielle Leffel. I am the Assistant Clinical Director and Education Director at Woodlake Addiction Recovery Center in Abbeville. I've been working in substance abuse mental health field since 2007. Excuse me, I am in recovery. I think that's really important for me to disclose because I was an opiate addict as well, and that was a really hard addiction and disease to try to overcome, you know. Let's see. Here at Woodlake, I've been working for Woodlake for about 5 years. Prior to that, I worked at a treatment center in Marksville called the Hope Center. In both treatment centers were, the model of treatment and the method of education that we used was recovery dynamics. Recovery dynamics is, the easiest way to really put that is a breakdown of each one of the 12 steps in a way that clients can understand it. And we utilize the big book of Alcoholics Anonymous in order to teach that. Here at Woodlake, clients, we treat them from A to Z, right? So we have detox. Detox clients are usually admitted into detox for up to 7 days with medications that will help assist with the withdrawal symptoms. Opiates, alcohol, and benzos are usually the 3 things that we have to use medications to try to detoxify clients. Once they're finished with detox, then they're in the same building, but they move to the residential level of care where they're expected to attend groups such as prayer and meditation, process group, which in process group, we really try to dig into the core issues that kind of precipitate addiction, or like, you know, what clients we use as a way to numb those feelings of that are associated with childhood trauma and unresolved grief and sexual abuse, family conflicts, maybe consequences due to their actions, as far as like maybe legal consequences. That'll be something that we try to process with them and help them see their part in. And so they do that 5 days a week, 3 hours a day. Then in the next part of the day, they will do education. During education, I teach the recovery dynamics, steps 1 through 12, breaking the steps down, helping them get in the big book, helping them to understand the big book of Alcoholics Anonymous a little bit better, because it's kind of a difficult book to read. And it's kind of breaking that down. We do implement AA meetings every night, and pretty much teaching them how to help each other and live in a structured community with one another. We do on 3 days a week, we do FCC's group, which is Fears, Cares, and Concerns, where each client is able to help each other identify some addictive behaviors that maybe the client has been displaying that maybe they didn't see in themselves, to help redirect those behaviors and help each other out. Let's see what else. We do offer, after residential treatment, it is usually 100% of the time suggested that clients follow the next level of treatment, the step down to intensive outpatient, and during while doing intensive outpatient, living in a structured sober living home, where they have support and accountability and rules and, you know, structure to kind of help navigate this new life of recovery. We do have a lot of homeless clients. We do have a lot of clients that are court ordered. And so this new family, so to speak, of support systems in their recovery is really important to help them get through those little weak moments. Intensive outpatient typically lasts about 2 to 3 months, depending upon insurance. Then after they've completed that level of treatment, Also, while they're in intensive outpatient, they will do individual sessions with one of our sister companies, Integrated Wellness. And those individual sessions will be conducted once a week with an individual counselor that they can work through some of those issues that they started to work on during residential treatment, the unresolved grief, some trauma therapy. We do offer EMDR, and just kind of have that one person that they can kind of depend on and get some therapy with. After intensive outpatient is outpatient. Outpatient typically lasts 3 to 4 months. So our program as a whole usually lasts about 8 months from start to finish, detox to end of treatment. I don't really have the statistics on what our success rate is, but I can tell you that any client that does finish all of those levels of treatment do have a really good rate of success. And we know that because they come back and they bring meetings to the people in residential. They'll come and tell their story during Unity, which is a gathering that we were doing once a month prior to COVID that we just started. We're going to start up again this month, where we had kind of an eating meeting, environment where we provide food and someone tells their story and people pick up years of chips. And so that kind of gives the newcomer some hope that, this program does really work. As far as medically assisted treatment, we do offer Vivitrol, and we usually start that process right at the time that they come to treatment. When they get here, they're in detox. Usually, if they're in detox, they're usually there, like I said, for about 7 days. From there, we will introduce and educate them on Vivitrol, what it is, what it helps, kind of like how Barry was saying. It does assist with opiates and alcohol. It does act as a blocker in the brain. And so what it does is it helps with the cravings, as well as, kind of when an addict has kind of a mental relapse and wanting to get loaded after they've taken the Vivitrol, the next thought hopefully is going to be, well, I can't do that because I've already had my Vivitrol shot and I'm not going to get high anyway. And so it kind of acts as a deterrent. While they're on Vivitrol, we try to get them approved for 1 year, but while they're getting Vivitrol at our medical clinic called St. Luke's, they have to be attending treatment. They have to be doing individual sessions because Vivitrol is not the solution to opiate addiction and alcoholism. It is just a tool that that we can use along with going to meetings, having a sponsor, working on unresolved issues and therapy. Let's see. I'll talk a little bit about the education that we provide here. As far as, the physical part of addiction, like I said earlier, we do recovery dynamics. This is a mental, physical, and eventual spiritual illness, addiction, alcoholism, opiate addiction, whatever it is. And so what we teach the clients here is about that mental obsession, those thoughts that tell us that we can keep getting loaded and that we're not going to have consequences, or that it's going to be different this time, or that, I can, use a little bit here and there. And we try to help them to see that, once you can remove those obsessive thoughts about the sneakiness of this disease, then you can really put into action some other things in your life that you really want to accomplish, right? So like being a better mother, being a better father, being a better son or a daughter or an uncle or grandfather, grandmother, and so we try to help them replace those obsessive thoughts of using with positive things and goal-oriented interventions. As far as the opioid epidemic, it's been really sad in the last year and a half since COVID to of what this has done to the program, or the fellowship, and people who've tried to come to treatment, and addicts and alcoholics, because of the isolation and inability to go to meetings there for a long time, or feeling disconnected and isolating. And I'm sure statistically there has got to be a huge rise in overdoses since the pandemic. and because of what they're putting in heroin and opiates these days, and pressed fentanyl pills. Like, people think they're going to buy Xanax off of the street, and it's not what that is. We've had several clients whose family members have called us after they left treatment thinking that they were just going to get a Xanax, and ended up taking a pressed fentanyl pill and not making it through. And so it's really disheartening and sad. But it's also good to see the success stories, the people who come back, the clients who want to eventually work in this field and get the opportunity to give back by working as a tech, or bringing meetings to the facility and sharing their experience, strength, and hope. I think that's all I have.
Great, thank you so much. So Mr. LaFleur, Ms. Leffel, we're going to go ahead and start our Q&A session. We do have a couple questions. Attendees, if you have any questions for our presenters, please put them in the chat box or use the Q&A function. So the first question we have, I'm going to address this to both of you. Do you serve court-appointed individuals? If so, what is the rate of recovery among this population that you serve?
So we absolutely do. A lot of our clients are court ordered. They are mandated to treatment. I don't really know the statistics of what the success rate is. I can tell you that it's probably pretty high, because of the fear of consequence of going back to jail, and, once a client is mandated to Woodlake, they have to finish every level of treatment. I also am an IOP counselor in the evening at ARC in Lafayette through Woodlake. I do have probably half of my clients are court ordered. And, they seem really willing, and a lot of them do step down to IOP and do eventually graduate. So that's my answer.
We accept court ordered kind of on a case-by-case basis. I'm maybe a little less optimistic, or I don't know. I've had some folks who have done fairly well. I sort of look at it clinically, like I really want folks who are interested in treatment. It's hard to tell sometimes if the pressure is so great from outside about how much they will internalize. And so we will take them on a case-by-case basis. Anecdotally, my success rate is not great on the folks that I have had. It's probably a little bit lower than, like I said, last year, my success rate was, let's say 27%, like finished the program, which again is, I think the national average is around 25%. Do 1 in 4 succeed? Probably, or close to it. I've got one guy for sure I could point to that said, oh, he did great. He came from across the state. I didn't think he would work out, and he settled in after a couple of months and did great. And I have had several folks who have had their court-ordered things taken care of while in treatment. So other than anecdotally, I can't tell you that it's huge success, but we will take folks and give them a shot sometimes.
Okay, so next question is from Miss Connie. Miss Connie asked, is Woodlake in Abbeville? Is there a sober living home in Abbeville?
So we are actually in the process of opening one back up here in Abbeville. We had one a few months ago. It didn't really pan out, but we still have the house. And so we are in the process of opening that up to a women's house. The name of it is Compassion House. And we're gonna just allow women to live there. As a matter of fact, we talked about it yesterday. We are in the process. So I'm thinking in the next week.
Great. Okay, next question is from Miss Angelita. How do you address drug use related stigma? And this will go to both of you.
I mean, I'll talk about stigma a little bit, I guess. I mean, to me, it's difficult. We do have folks, you know, who have a lot of shame involved with, you know, some of the things that have happened. I mean, we're hoping that doing the steps and doing the counseling and those types of things, and being able to, it's part of what group therapy does to some extent, is helps folks to feel less shame and less stigma related to that. But, you know, we do have folks who are going out and looking for employment and trying to figure out how to tell an employer what the holes in their resumes are for or why they're there. And we can't even give those folks a blanket answer like, oh, we'll be totally upfront and honest. I mean, you don't know exactly how that employer is going to react before they even hire you with that kind of thing. But we do tell folks to, you know, to make sure that when you're talking about getting employment, that you're not available a couple nights a week for IOP or whatever it is. You know, and I know the question wasn't about stigma with HIV, but I'll talk about that for a second as well, right? And stigma with HIV, you know, basically there are a lot of folks who have misperceptions about HIV, and you know, I still hear stories every now and then of family members like separating plates because they're worried that somebody's going to get HIV from eating off the same plate of somebody. Whereas in our facility, you know, we have folks who are positive and not positive, and people working in the kitchens and, you know, whatever. I mean, people, and we teach everyone about HIV. And so the thing that works for us is we teach everyone about HIV and substance use to a certain extent and other STDs and stuff. We do a kind of a comprehensive education day for all new residents, including our clients. And, you know, and we'll have folks even in our program that, you know, the staff knows that they're positive, but they won't come out with it. But we will continue to talk to them about it, about being able to kind of be open about that in treatment. We don't require it, but we do fully recommend it. And it's one of the reasons why we started doing that work here in the first place. And most of the folks feel vast amounts of relief when they're able to talk about it and realize that their peers are not freaked out by it and go, well, yeah, I could have easily gotten that too, you know, because I was an IV drug user. So.
Ms. Leffel, do you have anything to add to that?
I don't. Mr. Berry did a great job.
Great. Okay, so next question is from Melissa. For both of you, I'll address this. For your unhoused population, how do you deal with persons not having a state ID or driver's license? We are finding this as a barrier to accessing care.
So we usually, while a client is in treatment, we will help set them up with food stamps and get them set for the next phase of their treatment. When they get to sober living, there are advocates there that are people who have been there a little bit longer, maybe some senior residents that will assist with that, or the counselors, the IOP counselors, individual counselors. We will try to help them as much as possible. Yeah.
Yeah. We do the same. I mean, several years back, we just decided as an agency that, yeah, we will help people, you know, if they need to get, sometimes they have to get their copy of their birth certificate or something first in order to get an ID, but we'll do whatever we can to get them the ID. We'll front them the money for it. You know, we'll ask them to sign something to pay us back the $40 or whatever it might cost, $20. And, you know, we don't lose sleep if they don't pay us back. But we, you know, we will bring them ourselves to the DMV or wherever it is that they need to get so that they can have those things, so that, you know, so that they can get a job. I mean, they literally can't even start employment without an ID. So they're not going to go very far without that. So we've been doing that for years.
And we have a little addition to that question from Angelita. She says, I would add undocumented individuals. Are you able to serve them as well?
Yes. That's a little trickier. how should I say that? So I guess what I'll say is, maybe not the question, but with HIV care, I will absolutely make sure that they get HIV care. When it comes to residential treatment, and if they're undocumented, they may or may not have, they probably also don't have Medicaid. So then there's not a payer source. This facility, we gave up the indigent contract just because we had almost no one using it over the last few years. So I don't have an indigent contract. I will say that, on a case-by-case basis, we have taken folks with no ability to pay. But it kind of has to make sense why we would do that. If there's another agency that does do indigent work. So that's what I'll say to that.
So we have, in Abbeville, we have the grant program here that will assist clients with applying for Medicaid as well through Acadian Human Services. We're really grateful for that. We're the only facility that has the grant program in Abbeville. Woodlake does have several other residential facilities in Baton Rouge, Denham Springs, Bogalusa. And so we're the only one that has the grant program. So we're able to help those clients as well, just here in Abbeville.
Wonderful. Okay, and then another question that I have, I believe this is the last one, unless any attendees want to put some more in the chat box. Sue asks, when someone presents for treatment, but they are in need of pain management as well, how is that handled?
With non-narcotic pain medications. That's all we give them.
Yes, we have a medical director, and yes, we will do non-narcotic medications. You can switch off. For most of my clients, it's like up to 800 milligrams of ibuprofen. Sometimes they will switch from ibuprofen to Tylenol. We sort of allow muscle relaxers. If it's indicated, gabapentin is like a really big medication that a lot of our folks utilize. It's non-narcotic. And that's about most of it. And otherwise it's, and we have had folks, I've had folks that it's hard to tell exactly what's going on, but there's sometimes where it looks like folks are really just looking for that magic medicine, which will make them feel better. And if you just take the time, you will feel better without taking another medicine. And we have had success with folks kind of being able to kind of settle into the program and complain a lot less down the road without using it. But as far as for folks who have, severe back pain and all that kind of stuff and require narcotic meds, you can't do both at the same time. So yeah, you can't do that here. I said earlier when I was talking about Suboxone, at this level of care, I do not have round-the-clock nursing, and I'm not having narcotic medication on the unit without a chain of command, and so we just can't.
Okay, well, I believe that was the last question. So thank you, Mr. LaFleur and Ms. Leffel, for your time and for your great presentations. As a reminder, 1 week after the event, you will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. And again, if you dialed in by phone and are not logged on via Zoom, please email info@womensfoundation.com with your name and the phone number you dialed in from. And thank you all for participating, and I hope you guys have a great rest of your day.
Thank you. You too.
Thank you, y'all too.
Thanks.
Bye.